I am glad to be here. Um, I got interested in 1p36 because I had a patient that was brought in. She was about 2 years old. She was not walking or talking, and I looked at her and I could tell that there was something unusual, and kind of looked her over carefully and decided and ordered some genetic testing. Didn't really have a strong idea what it was. And a genetic counselor that I was working with walked in and said, she has 1p36 deletion syndrome. Well, I had heard of that. I had even seen it once before, but I had no idea. And I like, how do you know that? And she worked in the chromosome lab part-time, and she had seen the results in the pictures of the, I think, 7 kids that we had seen in the institution at that time. And that, so she turned out to be right. It was 1p36, and it's like, okay, it's recognizable. Now I need to learn so I can recognize it. And then the parents of that child came to us and said, okay, you told us the name of the condition, now give us some information on what we can do about it and what it means. And so we looked everywhere, and there wasn't anything. And so they said, well, this is not acceptable. We need more information. So we wrote a 1-page typed thing and gave it to them, and they said, this is pathetic. And so they did a fundraising thing and came in and said, okay, here's some money, write a brochure that actually is worthwhile, and let people know, because nobody should have to go through what we went through. Now, at that time, internet wasn't really a thing. And so we did that, and then we were like, well, now where do we send it? So we sent it out to all of the genetic centers over the whole country and sent them a stack of brochures. And then we didn't hear anything about it for a few years. And then I think that was one of the reasons that I was initially put in contact with this organization. And yet, based on the stories that we've heard during this time, it's not changed that much. There's still a lot of, I have no idea what to do with this, but there's a lot more information available now. And the question that we have and that I want to talk about is, how do you get to take advantage of that? So, healthcare system for 1p36, presentation in infancy, generally speaking. You might not get a diagnosis then, but you're going to know that there's something going on. Diagnosis comes with testing. There's descriptions of facial features that might be helpful to someone like me, but don't mean much to you, I suspect. Then you got to get plugged into the system of care. In some places, you have to go through a primary care physician for everything, and that person can use consultants, but tests have to be ordered, and communication has to go through the primary care. There are other places, and I work in one of the other places, where it's specialty care focused. So if somebody comes in to see me, I do things directly, I order tests directly, and I talk to them about what's going on, and that has some benefits and efficiency, but it also makes it more likely that I will do something, and then maybe some other specialist will do something, and they might be done out of order, or they might be incompatible interventions. So that's not good. It's a complex system. So as I was thinking about what to talk about here, I made a list of specialties that I thought people with 1p36 might need. And I stopped counting after I got above 30 different services. That's a lot. Now, nobody needs all of those things, or at least not very many people need all of those things. But almost everybody with 1p36 needs more than one professional involved in their care. And there will be some overlap between what the different people do, and sometimes there won't. They all have some unique things that they provide, and so we got to figure out how to get the most out of the system. So I'm just going to go through, and the first one is past everybody's needs who's here, because the children have been born. But we're getting a lot more prenatal diagnosis. So you go to an obstetrician, you get an ultrasound. If they see something that's unusual, there will probably be some testing offered. But even if you have a completely healthy woman and a completely healthy pregnancy, we are starting to pick things up early, because there are things like cell-free fetal DNA test that is, they might tell you this is a screen for Down syndrome, but it's Down syndrome and a bunch of other things, and increasingly that includes 1p36. That is a good thing in a lot of ways, because it will help get people plugged in sooner. But what do you do when you get news like your child is going to have a serious health problem, and I can't really tell you what that's going to mean because I don't know that much about it, but it's called 1p36 deletion. They may send you to a maternal fetal medicine specialist, which is somebody who is an obstetrician who does an extra 2 years of training to learn how to take care of high-risk pregnancies. And one of the differences is the obstetrician, for the obstetrician, the mother is the patient. And for the maternal fetal medicine specialist, the mother and the baby are the patients. So there's a difference in mindset. You don't usually get to pick who you see for those. You kind of have who you have. They get the diagnosis, or you get the diagnosis after delivery, and somebody should tell you what 1p36 is. Often a genetic counselor will be involved with that. And when a diagnosis of 1p36 is made, the parents should always be offered the opportunity to be tested to see if somebody has a balanced translocation. You've heard about this a little bit. The next person that we see is pediatrician. How many of the people who have 1p36ers who are still under 20 years of age need a pediatrician involved? All of them. Yeah, everybody needs a primary care physician because they can help with all normal health care needs. So things like vaccinations, ear infections, behavior problems, etc. Common everyday things, because people with complex health care needs still have everyday common things. And the pediatrician or family medicine specialist can also help you get plugged in for more specialized care. Part of their job is to recognize what the needs are. But what do they not do? It is unrealistic to expect your pediatrician to know 1p36 deletion syndrome when you first come in. It's a 1 in 20,000. So in a city of, say, 1.2 million, that means you'll get about 1.5 kids born per year. And in the city where I live, which is about that size, there are a couple of hundred pediatricians and family care doctors. So that means most of them will not have seen a case. They won't know this. So what do? Does that mean that you look for somebody else? Well, if you keep looking till you find somebody, your child might be grown up before you find an expert. So what you do is find out, will your pediatrician partner with you? Do you feel listened to? If you don't, then you need to let them know. And if you still don't feel listened to, then you need to find somebody else. But if they listen to you and they are willing to learn and they take your opinion seriously, even if they don't know much about it, that's probably a good person to have on your side. Pediatricians can also help to coordinate care, although most of them don't know that they can do that, and so you might need to prompt them. We'll talk more about that later. Probably most of you worked with neonatologists. They take care of sick newborns, and they are great at what they do, which is helping with feeding problems, breathing problems, infections, and other concerns that occur or are evident in the first days of life. And they will help to stabilize kids. They will help to get you ready to take your baby home and teach you the things that you need for the care in infancy. But what they don't do is long-term management. They don't keep you in follow-up and update plans. They hand you back to your primary care doctor. Most of them will have heard of 1p36 deletion, but many of them will not know 1p36 deletion. Neurologist. You've heard from a neurologist at this meeting, and neurologists, not everybody with 1p36 necessarily needs a neurologist, although pretty much all of them will have neurologic problems. So hypotonia, for example, what you really need a neurologist for is help with seizure management. There are also neurologists who specialize with mobility issues, tics, and other kinds of neurologic manifestations. So you can use those. How do you get the most out of your neurologist? This is a specialist. Why do you see your neurologist? Seizures. So if you go in and you say, if you walk into the neurologist's office, you get referred to the neurologist, and you walk in and you just say who you are, and then they say, well, what can I do for you today? And you're like, well, my pediatrician told me to come here. How good is the service going to be? Not very good. So what you want is to know, why are you seeing this person? My child is having seizures. We've had 4 this month. I need to know how much damage this is doing to my child's brain, and what medication, or what are the best methods for control? Is it medications? Is it surgical? Is it a vagal nerve stimulator? What's going to help? If you ask a question like that, you will get the attention. They will say, wow, this person knows what they're doing. I better be on my best game for this. Neurologists are very helpful. Many of them will have heard of 1P36. Most of them will not have lots of experience with it, but they know how to look these things up. They can find the information that's out there. We need to work on the quality of the information that's out there, but that's another topic. Okay, cardiologists, you might need, everybody with 1P36 should see a cardiologist because we need to look for structural heart problems. And the kids who have structural heart problems will automatically get plugged in for follow-up. The other kids, so the other thing that we need to look for, and it's been mentioned several times in this meeting, is cardiomyopathy. And that's an inefficiency in the way the heart muscle contracts and causes the squeezing effect that pumps the blood. And if you have the gene that's listed on this slide deleted, you are at risk for progressive cardiomyopathy, and you need long-term follow-up with the cardiologist. But if nobody told your cardiologist that, they might not even look for it. I've had lots of kids with 1P36 that I saw who were seen, they got an echo, they didn't have a structural defect, and the cardiologist said, goodbye, and didn't recommend any kind of follow-up. So how do you fight that? What do you need to ask your cardiologist? You say, well, my child has 1P36 deletion, and that is associated with progressive cardiomyopathy in some cases. What do we need to do about this? Again, you will get better service if you know what questions you need to have answers for. Now, for neurology and cardiology, that's pretty straightforward. Neurologists, seizures, hypotonia, and movement disorders, if you have those. Cardiologists, structural heart defects, cardiomyopathy. Cardiac surgeons, only if you have a structural heart defect and you might need a surgery. And they don't usually do the follow-up, the cardiologist does, unless they think that you need another surgery. Speech therapy. When might you need a speech therapist? You might need a speech therapist in the newborn period. You might need a speech therapist at age 1 or 2. You might need a speech therapist, but what do you need him for? What? Communication. So if communication is your big thing, what do you tell your speech therapist? Well, it depends on how old your child is and what's already been done, but if you have a 5-year-old and that 5-year-old has one word that they can say, it's usually mom, because moms come and then they know what to do. If the speech therapist has never heard of 1P36, and most of them won't have, then you will need to tell them what you know. My child has 1P36 deletion. That is associated with speech problems. Many of these kids will not be able to be fluent in speech. So I'm not really focused on completely on spoken words. I need a way of communicating with my child. What can you offer? You could also add, if you remember this, that apraxia is common, and that's a severe oral motor timing and coordination problem, and is one of the things that interferes with verbal speech in kids. if you know that and you ask those questions, the speech therapist is going to know a little bit more about what they need to do, and you will get into the augmented communication. So using devices, using sign language, using things besides spoken words faster. Now, I said some people need speech therapy in the newborn period. What do speech therapists do in the newborn period? Right, so your mouth, you need the same kinds of movement skills for your mouth to eat as you do to speak. The hardest thing newborns do is eat. Pooping and peeing happen automatically. Breathing happens automatically. Eating, they have to know how to do. So if a child is having a feeding problem, one of the things you want in early infancy is an assessment to see if they are moving their mouth correctly. Do they have the ability to coordinate feeding and to get that done? Again, you have to have the right questions asked, and your average speech therapist in early intervention programs isn't going to have a lot of experience with feeding. And they're going to tell you, you don't need a speech therapist until your child's more than a year old, because that's when speaking starts. But if your child's having feeding problems, you need a speech therapist earlier than that, or possibly an occupational therapist. So we did a study on speech in this meeting when it was held in Cincinnati, and this is some of the data from that. So you've heard already today a couple of times that often receptive language is better than expressive language. And that is true with 1P36. But 100% of the patients, of the kids that participated in the study, had both receptive and expressive language deficits. And there was a difference. If you look, 21 of the patients had severe expressive language delays. Only 7 of the people who were in that study had severe receptive language delays. So there's differences in the pattern, but there's a lot of need here. So you want to work with this. Don't ignore it. Don't wait and hope that they're just going to catch up. Work on it. The other thing that you can do with speech, and that people look at me like, well, of course, is talk to your kids. But the number of conversations that you have with your child correlates with the probability that they will move forward. And that is true both for kids in the general population and for kids with special needs. Now, that doesn't mean if you talk to your kids that they will all learn to speak in sentences. But they will get better at communicating if you continue to try to engage them. Other specialties, occupational therapy, you heard a lot about that. And they also work on oral motor stuff, so there's overlap between speech and occupational therapy. But the occupational therapists also work on a lot of sensory issues and fine motor skills. And again, you need to know which thing do you want them to focus on. If the problem is sensory overload and meltdowns, the therapy is different than if you are needing fine motor skills so that they can use a pinch or grasp more effectively. You got to know what your question is to get the best care. Okay. Physical therapy, the same. We just had a talk on that, so I will skip that. Gastroenterology, feeding problems. But most gastroenterologists, at least the ones that I've worked with, don't work on oral motor skills. They let speech and occupational therapy do that. So they work on the constipation, the motility issues, they, and again, you want to know what is the big thing. Is reflux a bigger problem than the constipation? And prioritize that. And you guys are the only ones that are going to know what's your number one thing. Okay. We'll skip that one. Ear, nose, and throat. Not everybody's going to need this, but kids who get recurrent ear infections, who have hearing loss, who have tracheal malacia or other upper airway problems are going to need an ear, nose, and throat specialist. And getting them involved early can help a lot. Sometimes there are surgical things that can help with feeding issues and with breathing issues. Sometimes it's not surgical, but you want to get the airway really well evaluated, and so there's a good chance that you will work with one at some point. Now this gets to what do I do? Because I don't have a body system that I focus on as a geneticist. And it's been mentioned several times in this meeting, genes don't change. So once you find out that there's a piece missing, do you ever need the geneticist again? So I think that that there is benefit to that, but it depends on where you live. So in about half of the genetic centers in the United States, the geneticist is primarily diagnostics. They are involved either in ordering the testing and explaining the results, or sometimes after the results are obtained, they are called in to say, well, what is this? We found a diagnosis, now what is it? And then they'll call a geneticist in for that. And they may only sit down with you and go through it one time. I don't think that that's ideal, but the reason that they do that is that there's a shortage of people who are trained in genetics. As an example, in the state of Nevada, there is one geneticist. There are 3.1 million people living in the state of Nevada. And the published numbers currently are that about 1 in 10 people have a reason to see a geneticist. So that one person is going to be really busy. So what they do is minimize what they are going to be involved with. But if you are in a place where there's more, what can a geneticist do? One, I live in the world of rare disease. So even if I find something that I've never heard of before, I know how to look up the information, and I am used to small numbers. So if somebody estimated that there are about 600 patients with some published data with 1p36, to me that's a lot. I see patients where there are 5 kids with that diagnosis, and I have to come up with something to do about it. So going to the geneticist and saying, I need you to help focus this. I need more information on what this means and what impact it will have on the life of my child. And being able to track that information down. Geneticists can also do care coordination. So if somebody comes to me and they need 10 specialists, one of the things that I can do is help them prioritize. Well, which one of these people do you need to see first? And the other thing that I can do is try to make the system a little bit more friendly and say, okay, you need to see 10 people. You can't see all of them on the same day because there's not that many hours in the day. But maybe we can get you to see 3 people on the same day, so you miss 1 day of work, and then you can get the care that you need. That kind of care management, I think, should be offered to every child who has complex care needs, but it's not. But if you ask for it, you might be able to get it. It depends on where you get your health care. If you go to a large children's hospital, there's a good chance you can get some help with coordinating care. If you do not, then it's currently unlikely. The only way to change that is probably to go to the state legislatures and the federal government and get them to change the laws regarding compensation so that they cover coordination of care. That's beyond my scope of practice. Okay, let's see. These are just pictures of kids with 1P36, but they have very different needs. So the one on the right side of this is a neonatal crisis presentation. The one on the left side of this is a neonatal cuteness presentation, but still has complex care needs. This one has a proximal deletion and has different facial phenotype than the more common distal presentation. This young woman has a very small deletion, and it only has 3 or 4 genes in it, so she doesn't have the facial features. She didn't have any birth defects. She had a mild intellectual disability and a severe oromotor apraxia. So there's a lot of differences in, so these kids actually don't have 1P36 deletion. The one in the wheelchair has a duplication. Now, Dr. Scott mentioned a gene called ARID1A, and that gene is in the 1P36 region. So the right side, the panel on the right side shows kids with deletion of that gene. And if you look at that, you will notice that there's a lot of overlap with kids with 1P36. And that syndrome actually looks a lot like 1P36. It also looks a lot like the kids with RERE deletion and with SPEN deletion. And there's probably at least 6 genes now that are proposed to explain most of the 1P36 phenotype. And none of them actually do, but they all contribute to it in an important way. The one on the left here has a duplication of ARID1A, and that also is problematic. So we talked, well, Dr. Scott talked earlier about gene therapy. So the gene therapy is going to be complicated if we ever get good enough to do it, because, as is evident from that picture, too much is sometimes as bad as too little. We would have to be able to put in a gene and the instructions to control its expression appropriately so that we hit the right balance. How many genes are there in the 1P36 band? Lots. Over 300. So the genes Dr. Scott went through, the genes that he is currently interested in, that he thinks make a major contribution to the thing, he mentioned 9. That is about 0.3% of the genes that we've got an idea of what they're doing and that we know a lot about. We got a lot to learn. don't let that make you believe there's nothing we can do now. Okay? There is more that we can do. One of the big things that we deal with 1P36 is behavioral and developmental issues. So there are specialists who deal with this. One group is developmental pediatricians. So they are trained in pediatrics, general pediatrics, and then they are trained in how to assess and manage developmental delay. If you have access to one of those, that's a good thing, a good person to use. They know medicines that help with attention. They know medicines that help keep people calm. They know medications that can help to regulate sleep. They also know non-medical interventions for each of those things, non-pharmaceutical interventions for each of those things. And they work with other people like speech therapy and occupational therapy and physical therapy to implement those plans. But most of them will not have much knowledge of 1P36, so you need to go in knowing what you want. What is the thing that is the top priority? If it's temper tantrums, talk mostly about that. And then when you come back, after the temper tantrums are addressed, then talk about the next thing on your list. And that might be communication skills, and get a plan for that. Now, developmental peds are only one of the groups that does that. Neurodevelopmental psychology, these are psychologists, not physicians. They don't prescribe medication, but they are really good at finding strengths and weaknesses in learning. And if you know what the strengths and weaknesses are for your child, the chance that you can get a better plan for them to move forward go up. The more you understand about what you need, the more likely it is those needs will be met. So these people are very useful as well. They often work with developmental pediatricians, but not always. In my hospital, I can refer someone to clinics that have both, some that just go to developmental pediatricians, some that just go to neurodevelopmental psychology. The way I decided is who has the shortest wait list to get in, but you can also decide it based on the quality of the care and the reputation of the providers in your community, or on the specific needs that your child has. And I don't have time to go into that in a lot of detail. Psychiatry. Now, a lot of people don't want to see a psychiatrist or to admit that one could be helpful. But psychiatrists are trained to assess behaviors, and particularly problematic behaviors. So when your pediatrician or your neurologist or your developmental pediatrician run out of ideas for the child who is, say, biting themselves and causing significant injury, they turn to psychiatry because that's who has the most experience with those problems. Now, psychiatrists don't have as much experience with intellectual disability, so they may need to team with your developmental pediatrician, but that's okay. We don't need to limit the number of voices, we just need to coordinate them and get them focused. So they work together. Use psychiatry, but for 1P36, you'll need people who are pediatric psychiatrists, not adult psychiatrists, because the adult people will use too many sedating meds, and as long as the person is quiet, they'll consider it a success. That's not a success. We want kids to be calm enough to function, to be able to focus on making progress, and awake enough to be able to make progress. How many of you have heard of physical medicine as a specialty? Few people. A lot of people and adults use physical medicine. Physical medicine and rehabilitation is the formal name of the specialty. They work on mobility issues and on ways of improving function. For the kids with 1P36, they would be involved in a lot of the same needs as orthopedics. But orthopedics are surgeons. They know how to use a knife. They want to go to the operating room. They want to do procedures. Physical medicine don't do surgery. So they focus on what else can we do. They're good with bracing and devices that can help you. They're good with finding focuses for physical therapy and ways of augmenting mobility and functionality using PT and support devices that you need. Now, the hard thing with this one is that there's even a bigger shortage of pediatric physical medicine practitioners than there is for geneticists. So finding them is a little bit challenging. If you live near a children's hospital, you should ask about physical medicine if you need it. And if they don't have it, you should let them know that that makes you unhappy. Not in a rude way, but in a way that encourages them to change. Complex care is this is a new subspecialty in pediatrics. It's for kids who have multi-system involvement, usually severe developmental delays, and a lot of times mobility issues as well. So cerebral palsy is their most common diagnosis, but probably at least half of my patients with 1P36 deletion are followed in the complex care clinic. Most cities have people who do this. Not all of them are formally trained and certified in complex care, but their practice focuses on it. That is very helpful because they are used to the kinds of problems that you're dealing with and aren't going to be overwhelmed by the complexity of the patients. So look for those practitioners. They are really comfortable with G-tubes and wheelchairs and things like that. They are good at finding access to those things and getting insurance to pay for them. So use the resources, and if you are frustrated and not getting something that you need, you can ask your pediatrician, who's a general practice pediatrician, who can you send me to who knows complex care? And you don't necessarily give up your primary care doctor to do that, but they can help you to get access to the things that you need. Palliative care. Now this includes hospice, but it isn't equivalent to hospice. In adult medicine, in many places, if you say, I am going into palliative care, that means all we're going to do is give you comforting care. We're not going to try to cure anything. We're not going to try to maximize function. We're going to keep you comfortable and wait for you to deteriorate and die. In pediatrics, there is a sliding scale, and people move back and forth on it. So you can simultaneously be getting comfort care and life-saving care. You can be in palliative care and still get your heart surgery that you need, or still get treated with even very expensive high-tech medications if they are appropriate. The focus of palliative care is quality of life and comfort. Their big issue is pain management, but they can do other things as well. So pain and anxiety are their sort of main primary focus, but a lot of palliative specialists will also be able to do complex care and can help with that. They are really good at getting home-based complex care done. So looking for those, asking for that kind of service, even if your child is not end stage, is helpful. So when I started in Cincinnati, the only thing we used palliative care for was the kids who were dying, who were at the end stage. Now, when we know a child is going to be born with multiple complex needs, we have them meet with palliative care prenatally. They help with the birth plan. They help with the transition to home care plan, and they sometimes follow these kids for years into the future. Think about the things you need. What is the next thing that your child needs? How do you need to get that addressed? And then look for those services and ask for them. And the more you can explain about what you need, the more likely it is that you will be able to find that. Now, these are the ones that I found, or some of the ones that I found. This still isn't a complete list, that might be useful, but we don't have time to talk about today. So, keys to success in using the healthcare system. One, you need to know what you want and what you need. And it helps, at least for me and for most of my patients, if you have them written down. What are your top priorities? Before you get to the doctor's office, when you are talking to your healthcare providers, frame it in a positive way that implies that you appreciate the help and support that they are about to give you. If you go in and say, this is what I want and damn it, you better give it to me, you're not going to get good care. If you go in and say, I'm not really sure why I'm here, but it was on my schedule, so you're probably not going to get good care with that either. If you go in with a list of things, these are my things, and you know which are the priorities. What is it that at this time in your child's life is the next thing, or is the biggest thing that's keeping them from moving forward? That's the thing you want to go in and talk about. And having that list will help you to prioritize who do you see first, and then when you see any individual, which questions to have them focus on. You won't be able to solve all the problems at once. We wish we could, but we just can't do that. But you can get good care. And you will get good care best if you go in prepared. Thank the people who help you, because doctors, like toddlers, thrive on positive feedback. It's embarrassing, but we have to admit it. Be flexible, be open-minded, and expect your care providers to do the same thing. The usual care is often useful, but it's not the only thing that we should use. especially when we know that the kids, like the ones in this meeting, have needs that are not the usual needs. The usual care is probably not sufficient for that. You want to look outside of that. We need to be open-minded, but don't try random things just because you can. When you are trying a new therapy, so for example, if your child's having seizures and you want to try CBD oil, you want to have a specific goal in mind. You need to know how often are these seizures occurring, how severe are they, and then have some way of tabulating that. Then you start the CBD oil and you see if that change comes. If it doesn't, if you don't do it that way with specific goals, then what you end up doing is just adding new things on top of new things on top of new things, and then you start to get complications because you've got too much polypharmacy. You try things, and if it works, then you keep it, and if it doesn't work, then you stop that one and you try something else. If something has worked, and now it's not working as well, then you might need to add another therapy or maybe change to a different one. And that's where you would need to talk to the provider that's caring for that. You will note that I'm sort of obsessively emphasizing talk to your providers. Now, the providers are only going to have, for the primary care providers and the high throughput clinics, they will have no more than 15 minutes to spend with you. That's why you got to have it written down and have your priorities all tabulated. The specialists who are thought-based might have 30 to 45 minutes to spend with you, but not more than that. So again, you're going to have your priorities in mind when you go in seeking care. You do that, and then if you don't know what to ask for, talk to your primary care physician, or if you have access to somebody who knows the condition well. So if you have a geneticist, they should be able to, at least, even if they don't know 1p36 real well, they know how to look that stuff up. Expect them to do that. Expect them to help you come up with the questions that you need to ask for the neurologist and the cardiologist and the gastroenterologist and all of the other ologists you need to see, because you will get better care when you do that. So aspirational goals, this is long into the future probably. Include care management for all patients who have the kind of complex care where you can make a list of 30 specialists that might need to be involved. We also have enough data now that it's time to write a specific recommended management protocol and start seeing if that works. And to get the most out of both of those things, we also need a centralized data collection, something like the registry that exists for 1p36, and we need to improve the amount of data that's going into it and to have a planned approach to analysis. Some of that is going to have to be on providers to do, but you guys should also have a voice. I think that this group should consider having a committee that makes a list of priority items and says we need more information on these topics, and then we can look for people who are willing to do that research and target those needs. And I will stop there.